Hi everyone, this is our first screencast for this class, and please listen to this recording prior to our cases that we're going to look at come this Wednesday. So in this first screencast, we're going to be looking at the integumentary system. Our skin is the largest body organ. It makes up about 15 to 20% of our body weight. There are three primary layers. Primary function is to protect underlying structures from external injury and harmful substances. Other functions include helping to hold organs together, sensory perception, it contributes to fluid balance, controls temperature, absorbs UV radiation, and metabolizing vitamin D. You're not responsible for this slide. This just illustrates the different layers of the skin, many of the structures that are found in those layers, and their functions. So it gives you a good appreciation for the importance of this structure of our body. 1 in 4 people have a skin disorder. There are a variety of causes. There are primary and secondary skin lesions. A primary lesion is the first one to appear on the skin, and it has a visually recognizable structure to it. A secondary lesion occurs when the primary lesion changes. And this may be due to scratching, itching, medication, the natural disease progression, or the healing process. Here are the common signs and symptoms of skin disease. Pruritus, that's itching, a common manifestation of many skin diseases. Urticaria, that's hives, so that vascular reaction marked by the appearance of smooth, slightly elevated patches. This can also cause itching. A rash being the generalized term for an eruption on the skin. Here we see examples of people presenting with hives. Blisters, fluid containing elevated lesions of the skin with clear, watery, or bloody contents. Xeroderma, this is a mild form of dryness of the skin, characterized by dry, rough, discolored skin with the formation of scaly desquamation. So basically the shedding of the epithelium in small sheets. Other symptoms associated with skin disease include moles, cysts, which are sac-like pockets of membranous tissue, fibromas, which are a fibrous connective tissue growth that is benign in nature, a nodule, which is a growth of abnormal tissue developing just below the skin, swelling, and changes in one's nail beds. Let's take a look at some common skin disorders. The first is eczema and dermatitis. These terms are often used interchangeably. They describe a group of disorders with a characteristic appearance. So, it's a superficial inflammation of the skin that can be caused by irritant exposure, becoming sensitized to something, so developing an allergy over time, and genetically determined idiopathic factors. There are 3 primary stages of eczema and dermatitis. These 3 stages are the acute, subacute, and chronic dermatitis stages. Now, each stage has some similar presentations and some different presentations, but somebody can manifest all 3 stages at the same time too. Here are a few pictures of dermatitis. Dermatitis is common in older adults. It can be caused by many things, including allergens, hypoproteinemia, venous insufficiency, an underlying malignancy like leukemia or lymphoma, and it can also be caused by drug-drug interactions. And so you may have a patient that has this presentation It's not uncommon because many older adults may be on several drugs. Let's take a look at atopic dermatitis. This is a chronic inflammatory skin disease, the most common type of eczema. It can present as early as the first year of life, and it affects greater than 10% of children. Atopic dermatitis is an early manifestation of atopy. So that's the genetic tendency to develop allergic reactions. Atopic dermatitis often appears before other types of allergic reactions like allergic rhinitis or asthma. Usually individuals that experience this have a familial history. Atopic dermatitis is often associated with food allergies. Exact cause is unknown and the pathomechanisms are also unknown. They likely involve immediate and cellular immune responses. This begins often in infancy as a red, oozing, crusting rash, and early on it's diagnosed as acute dermatitis. As one grows, the chronic form develops, or I should say maybe the chronic diagnosis is made, where the individual progresses from that red, oozing, crusting rash to more of the dry, thickened, and brownish gray looking rash or skin presentation. The rash tends to be localized to large folds of the extremities, like the knees and the elbows, but it also can appear in the neck, the sides of the face, the eyelids, and the back of the hands and feet. Major symptoms include xerosis, so abnormal dryness, and of course, pruritus, that unpleasant sensation that requires one to scratch. Now, as one scratches, that leads to lesions, infections, and scarring. Areas at risk for secondary skin infections now happen because of the scratching, so it increases the chances of bacterial, viral, or fungal infections. And a common bacterial infection is the Staph aureus. Now, this can resolve spontaneously. Oftentimes, though, treatment involves educating people on good hygiene, the avoidance of irritants, so identifying those foods that seem to cause the rash. Topical pharmacology may be beneficial, and sometimes systemic medications are prescribed, like antibiotics. You might expect that if there was a bacterial infection. Also, antihistamines and, in rare cases, corticosteroids are prescribed. Contact dermatitis, this can be acute or chronic. It's caused by exposure to a variety of agents. It's the most common skin disease that occurs at any age, and people, as they get older, may develop hypersensitivities, why they would develop contact dermatitis then at an older age versus a younger age. There's a lot of common sensitizers, and those are listed there. One in particular that we need to be aware of is silicone. So silicone is a common interface between a prosthetic device and one's skin. And so if you are a therapist working with those populations, it's important to investigate the skin and address that if indicated. Clinical manifestations include intense itching, redness, and edema. These symptoms may occur at the site of the exposure, or they may extend outward. They may progress to vesiculation, oozing, crusting, and scaling. Diagnosis is based on history and exam. Treatment includes removal of the offending agent, avoiding contact with soaps, detergents, bleaches, and strong chemicals, lubricating the skin with moisturizers, using topical anesthetics or steroids, and for those who are unable to avoid the known allergens, immunosuppressant therapies may be indicated. Stasis dermatitis, this is the development of areas of very dry, thin skin and sometimes shallow ulcers of the lower legs. Your client will often have a history of varicose veins or DVT. DVT, of course, being a clot. Varicose veins, these are those swollen, twisted veins that lie just under the skin. They usually occur in the legs. Varicose veins are a common condition caused by weak or damaged vein walls and valves. Clinical manifestations include itching, feeling of heaviness of the legs, brown stained skin, and open, shallow lesions. The lesions are slow to heal because of a lack of oxygenated blood. Treatment includes gait training or walking. It's described as gait training in your text. This isn't the type of gait training you would do when you're walking somebody in the acute care setting of the hospital where you're just trying to work on getting up and increasing their physical activity. This is walking to get those muscular contractions. The contraction relaxation will help to push things through the venous system. Also, compression hose should be used when in a recumbent position. Environmental dermatoses, this is due to exposure to various environmental chemicals and physical stimuli. Listed in box 10.6 are many different things that can cause a skin disease. Common environmental skin diseases include irritant or allergic dermatitis, acne lesions, pigment changes, photosensitivity reactions, and infectious disorders. Rosacea, this is a chronic facial disorder of middle-aged and older adults. It's a form of acne. It's differentiated by age, so they're older adults versus how you might think about teenagers developing that kind of classic acne. There's a presence of a large vascular component you can see as demonstrated here in this picture. And there's the absence of comedones. Comedones being those small bumps or papules that are frequently found on the forehead and chin in individuals with acne. Those are basically our blackheads and our whiteheads. This has been linked to GI disturbances. There's a causal relationship between rosacea and the Helicobacter pylori. Sun, hot weather, and humidity can trigger flare-ups. Now, skin infection. Lots of different skin infections that are out there, many bacterial, viral, fungal, and other parasitic skin infections that are encountered by us are not the primary focus of our interventions, but we will see them in our clients. We might see them if they're hospitalized. We might see them if we're doing home health, or if they come to us in our outpatient centers. Many of these conditions are contagious and require careful handling to make sure we don't spread them to others. Sources of skin infections will differ depending upon the disease and the mode of transmission. Predisposing factors to skin infections include ones having a decreased resistance, dehydrated skin, burns or pressure ulcers, having decreased blood flow, contamination from nasal discharge, and poor hygiene. Bacterial infections, so there's normally a variety of bacterial flora on our skin. Organisms will enter the skin through abrasions or puncture wounds. People who are at risk for infections are those who are immunocompromised, those receiving immunosuppressive therapy. Immunosuppressants, they stop our immune system from damaging our healthy cells and tissues, so people with organ transplants or stem cell transplants may be taking these medications. People who are debilitated, who have a debilitated physical condition, may be at a greater risk, and those with malignancy. Examples of a couple bacterial infections include impetigo and cellulitis. Impetigo is a superficial skin infection commonly caused by staph or strep. Most commonly found in infants, children 2 to 5 years of age, and older adults. Predisposing factors include close contact in schools, overcrowded living quarters, poor skin hygiene, anemia, malnutrition, and minor skin trauma. It spreads by direct contact, environmental contamination, or an arthropod vector. Often occurs as a secondary infection. Clinical manifestations include small macules, vesicles that become pustular. When the vesicle breaks, a thick yellow crust forms. There can be cellulitis, which is a bacterial skin infection presentation, and itching. Medical management for small lesions, soaking for 10 minutes with drying agents. For small to large lesions, a physician may have the patient take oral antibiotics. Cellulitis, this is a rapidly spreading acute inflammation with infection of the skin and subcutaneous tissue. Strep or staph are usually the causative agents in adults. Influenza B, as well as other pathogens, are observed in children. Clients at increased risk for cellulitis include older adults, those with diabetes, those with malnutrition, those on steroid therapy, and if there's the presence of wounds or ulcers. Other predisposing factors, presence of edema or other cutaneous inflammation or wounds, venous insufficiency, thrombophlebitis, surgery, substance abuse, immunocompromise, and lymphedema. Medical management includes IV antibiotic infusion, good nutrition and hydration. Extensive cellulitis may require surgical debridement of necrotic tissue. Viral infections, these are intracellular parasites that produce the effect by using the intracellular substances of the host cell. Herpes zoster, also known as shingles. This disease is brought about by the varicella zoster virus that causes chickenpox. The initial infection, common in childhood for those who didn't get the vaccine. Shingles may reoccur between the ages of 50 to 70 or any time in life. I had an outbreak when I was in my early 30s. By the age of 80, 15% of people will have experienced at least one episode. What will be interesting is to see if those who have the vaccine, if they have lifetime immunity, meaning many of you probably had the vaccine, did not have chickenpox. And so the question is, will that provide you lifetime immunity, or are you at risk for developing chickenpox later in life and then having shingles at some point after that? I don't have the answer to that. My guess is you have lifetime immunity. Pathogenesis, it results from the reactivation of the varicella virus that has been dormant in the cerebral ganglia or ganglia of the posterior nerve roots. So after somebody gets through the chickenpox, it stays within the body and hangs out in these areas. The immunologic mechanism is not well understood. It's thought that the virus multiplies as it is reactivated. It's usually brought on when somebody is in an immunocompromised state that may be associated with stress, advancing age, having an underlying malignancy, having an organ transplantation, or those individuals that might have AIDS. Now, if somebody does not have effective antibodies, then the virus will continue to multiply in the ganglia, destroying the host neuron. It then spreads down the sensory nerve to the skin. Clinical manifestations is a vesicular eruption along a dermatomal pattern. When I had it, it was more of a circular pattern on my back. It did not have the presentation as is demonstrated in this slide or the prior slide or the next slide. Symptoms include pain, tingling along the dermatome, fever, chills, malaise, and GI disturbance. Medical management is diagnosis by visual inspection. There's that clinical examination, and then labs may be performed. When I was diagnosed, there was no culture or histological examination performed. Basically, I went into the ER because I was experiencing the fever, chills, and malaise. I wasn't having any type of tingling or pain at the time. And the admitting nurse took a look at it and said, "You've got shingles." And I thought, "You're crazy because this affects older people." But that was confirmed also by the doctor and was successfully treated with whatever they treated me with at the time. So a lot of times, just that visual inspection, that presentation is enough for a diagnosis to be made. Prognosis is good. There's no curative agent. Corticosteroids prescribed within the first week. They may help to abort the attack and reduce acute symptoms. Viral drugs will stop the rash progression and reduce symptoms. And this is important here. If one is hospitalized, but not hospitalized because they have the virus, usually the virus would not be the type of thing that would make you go to the hospital. If you're in the hospital already and you develop this, you're put in an isolation room, and anybody working with that patient needs to use protective measures because you don't want it to spread to others. At the time, I was working at a hospital when I had my outbreak, and I had to wait a couple days before returning to work once my symptoms had gone away to make sure that I was not potentially going to pass it on to people. Now, for prevention, there is a vaccine that is usually recommended for adults either 50 or 60 years of age. I know listed there the shingles vaccine listed as adults 60 and older, but now that's down to 50 and older. Warts, these are common benign viral infections of the skin and adjacent mucous membranes caused by the HPV virus. There are 50 different varieties of this virus. The incidence of warts is highest in children and young adults, but warts can occur at any age. Transmission due to direct contact. Auto-inoculation is possible. Warts may appear singly or as multiple lesions with thick white surfaces and may contain many pointed projections. Clinical manifestations depend upon the type of wart and its location. The most common is the verruca vulgaris, frequently found on hands and feet. Diagnosis based upon visual examination. Treatment, some of these disappear spontaneously. Treatment recommendations are based upon wart location, size, the number of warts, presence of secondary infections, age, gender, and history with prior treatments. There are over-the-counter applications. Medical treatments include cryotherapy, so liquid nitrogen or solid carbon dioxide applied. That can be painful. This causes epidermal necrosis. The area dries and peels off together with the wart. Acids can be painted onto the wart. This is also painful. And electrodesiccation and curettage. This uses high frequency electric current to destroy the wart, followed by surgical removal of the dead tissue. Fungal infections caused by fungi that invade the stratum corneum, the hair, and nails. The fungi can't live in the deeper layers of the skin, so it has to multiply as fast as the outer skin layer is shed. It will spread without treatment. Common examples include ringworm and athlete's foot. Ringworm is Tinea corporis, marked by the formation of ring-shaped pigmented patches covered with vesicles or scales. Transmission via direct contact with infected lesions or indirectly with contaminated objects. Diagnosis based upon a lab exam. Treatment, antifungal powder, a topical agent. Also keep the skin dry and clean. Here's another picture of ringworm. Athlete's foot causes redness, skin peeling, and itching between the toes may spread to the sole. Severe infection may result in inflammation with severe itching and pain on walking. May develop an odor. Treatment to keep feet dry and clean and use antifungal cream or powder. Parasitic infections. Some parasitic infections of the skin are caused by insect and animal contacts. Substances deposited by insects are considered foreign to the host and may create an allergic sensitivity. Scabies, highly contagious skin eruption caused by a mite. The female mite burrows into the skin and deposits her eggs. These hatch into larvae in a few days. Transmitted by skin-to-skin contact or by contact with a contaminated object. Can spread rapidly. So think about nursing homes, skilled nursing facilities possibly. The inflammatory response and itching do not occur until 30 to 60 days after initial contact. Symptoms include itching, excoriated skin, and the burrow. The burrow is the linear ridge with a vesicle at one end. The mite is usually found in the burrow. Diagnosis is to dig the mite out and examine it under microscope to confirm. If the mite is not found, the diagnosis of scabies is presumptive. Treatment includes a scabicide, either a lotion or cream. Pediculosis or lousiness. This is an infection by the pediculosis humanus. Transmission from one person to the other via combs, lockers, and clothes. Okay, we're talking about lice here, right? Usually that thing that gets spread around elementary schools. It affects school-age children, people who live in overcrowded surroundings, and older adults with poor hygiene. There can be head lice, body lice, and pubic lice. Treatment, cleaning solution, so shampoo or soap containing permethrin. Oral dose therapy of ivermectin is effective at stopping the infestation. Skin cancer. American Cancer Society reports that skin cancer is the most prevalent form of cancer. Eventually affects nearly all Caucasians over the age of 65. There's much lower rates in Latinos, Asians, and African Americans. Over 1 million new cases of non-melanoma each year in the US. Listed in box 10.8 are the types of skin cancer. We'll explore some of these in class. Screening for skin cancer follows the A, B, C, D, and E. Please feel free to read through this. We'll also discuss this in class. Here again is the A, B, C, D, E method of early melanoma detection. And of course, this is important because as physical therapists, we are inspecting people's skin. Now, it's not our job to diagnose melanoma, but we may have opportunities to have conversations with patients, especially those patients who've not worked with their provider in a long time. Risk factors for the development of malignant melanoma are presented here in box 10.9. I won't read through these. You can pause the recording and read through them. Guidelines for the prevention of skin cancer, same thing. I won't read through these. Go ahead and pause the recording and read through them.